Hello, InstaFam. It is Dr. T here, coming to you on the last Wednesday night of winter. Well, winter in the Southern Hemisphere anyway. I'm so stoked. I can't tell you how excited I am that we have 3 more days of winter to go, and then we're into the best half of the year as far as I'm concerned. So yes, hope you guys are all well. Hello, Michelle Arnold. Hello. Welcome. Life of Brit is on. Hello to the Merck team. Oh, lovely to see you guys on a Wednesday night. Laura Jane's here. Oh, this is fabulous. Lovely to have you guys on. So Q&A, feel free to drop a question into the comment section. Try and make your question not your life story. Try and make it as generic as possible. I'll be giving a fairly generic answer, blah, blah, blah. You know the drill. But while I'm waiting for something to flash up on the comment section, I want to talk about a case that I had this week. Because I feel sometimes in the fertility space, the male component of this is often not well considered. I think as a fraternity, we probably don't do as good a job on our guys and their reproductive health as we probably could. So the long and the short of the story, hello Davina, is that I saw a couple this week who are going to be having IVF, and this particular guy had seen let's just say a doctor who was interested in hormonal management of men, not an endocrinologist. And he had gone to see this doctor because of issues with vitality and energy and so on. And a testosterone level had been taken. It was shown to be in the lower end of the normal male range. And, I can see a question. I will come back to that. Ooh, what a juicy question. I'll come back to that for sure. Anyway, what the long and the short of the conversation was that this gentleman had been put onto testosterone therapy to help manage his vitality. And although he did report that his energy had somewhat improved, my greatest concern was the lack of education that had happened around the impact on his spermatogenesis or generation of sperm. So I just wanted to do a quick little biology lesson to those of you who might be interested in this topic. So much like the female system, there is a brain, right? There is a pituitary gland that kind of hangs off the brain. There are gonads, we'll call them testes, and there is a hormonal communication that happens with these two systems. And so by giving a man exogenous, so let me just step back a second. The pituitary gland produces hormones, FSH, follicle stimulating hormone, just like with a woman, and LH, luteinizing hormone, just like with a woman. The follicle stimulating hormone in a man helps him to produce sperm. So FSH, S for sperm, and the LH component encourages the production of testosterone from the testes. So blokes' gonads do 2 things. They produce sperm and they also produce testosterone, which is vitally important for a man's vitality and his bone health and his muscle strength and his libido and all of those things. So it is an incredibly important hormone. However, here's the problem. If you give a guy exogenous testosterone, and it can be in a cream form, it can be in an injection form. Sadly, we don't have tablets yet, but if you give them exogenous testosterone, that will signal to the brain that he does not require the production of testosterone. So it signals the hypothalamus. The hypothalamus then says to the pituitary, you don't need to produce this, so let's shut these 2 hormones down. So not only does he stop producing his own testosterone, but sadly, he also stops producing sperm. And so what has inadvertently happened to this man who is due to go through IVF is that he is no longer producing sperm. Now, we can simply stop the testosterone injection, but almost certainly before his body has had an opportunity to start producing testosterone, he will tank, he will feel terrible, he will feel fatigued, he will feel weak, he will be going to bed early, his libido will be in his boots. And sadly, that is something that the medical fraternity have done to him. Will his sperm production come back? Yes. How long might that take? Potentially months, sometimes even years, depending on how long he has been on that testosterone therapy. So I think it's really, really important that if you are a man or if you're a partner of a man who is seeking assistance from doctors who prescribe hormones, it's really, really important that they understand the implications of what giving somebody exogenous testosterone might also do to his sperm production. So I just thought I'd share that with you today, because when these guys came to see me, they were quite surprised. No one had actually discussed the implications of taking exogenous testosterone. All right. Oh, May, it's 35 degrees here today. Where are you, my friend? Goodness, I wouldn't mind being there. Now, somebody has asked a question. Let's jolly on through. May, wherever you are, May. How well regulated are donor sperm? Gosh, that is such a loaded question. I'm sure that's coming from somebody who has watched The Man with 1,000 Children on Netflix. I guarantee it's a very eye-opening, thought-provoking watch, that one. How well regulated are donor sperm? I guess that depends on where they come from. So I can really only talk to what happens here in WA. So we have a particularly conservative system, and I think for good reasons. There has been a lot of research done in the donor-conceived children's space, and certainly we have determined in that space that they don't want to have a lot of donor siblings. And so here in WA, donors are well versed in the fact that they can donate to 5 families in addition to their own families. Of course, that can be as many children as they like within those families, but yes, 5 families. In some states around Australia, it is 10. They are considered global families as well. So the big question, I suppose, might be thinking is, well, how do we know that people don't go and donate in other countries? I guess the long and the short of it is we probably don't know. And so that is the issue with known donation. Is certainly here in Western Australia, we can advise donors, we can ask them to comply with West Australian regulations. We have a very good registry which keeps a track of that here in WA. But as to other clinics around Australia and around the world, we can't really regulate what happens in those other clinics. And certainly what I got from the story around The Man with 1,000 Children is that there is certainly a call for a global donor registry. And I certainly think that, they were talking for a European donor registry. I call for a global donor registry. Whether that is an achievable thing, I'm not sure. But certainly I think the children conceived a donation and also donor recipients have the right to be considered for something like that. So here in WA, well regulated from that perspective. That's why I think sometimes known donation might or recipient recruited donors may be a better option. But again, you can't really confirm that they haven't gone and donated overseas. You can only sort of trust that they are following the regulations. So how well regulated are donor sperm? I guess it depends on the region or the place that you're talking about, but certainly in WA, I feel that we have a pretty good system. So hopefully that has been helpful. Michelle Arnold, scenario: a woman who doesn't need ART would like to freeze her eggs at a young age to use later when their quality would potentially be poorer because she doesn't need IVF and can fall pregnant. Michelle, the rest of your question hasn't come through. Maybe you hit send by mistake. But I'll just talk about that. So what you're asking about is fertility preservation, because we don't know if that young woman is fertile or if she is infertile, but she'd like the opportunity to use her eggs later in life. So one would assume that she would only come back to use those eggs if she is infertile at that later stage. So for example, let's say a woman froze at 30, she comes back at 39 with her partner. They have been trying to conceive for 6 months. Technically, therefore, they are deemed subfertile by the definition. And so at that point, she can choose to utilize her previously frozen eggs for IVF, and in the case of frozen eggs, for ICSI. So I'm wondering if that's what your question was about. How can she create embryos if her fertility has never been tested? Well, by the time she is due to use those eggs, her fertility has already been determined. So I'm assuming that's what you were asking, but yeah, good question. I've often been asked that one. How do you prove their fertility? Well, they usually come back having not been, because let's face it, nobody really wants to do IVF. Everyone would much prefer to have spontaneous pregnancy. I certainly know that I think it's a much nicer journey than IVF. Ask anyone who's been through it. Mika Georgie, microtessie success rates with low sperm count. Well, microtessie is often not done unless somebody is azoospermic, meaning no sperm, because if you've got a low sperm count, i.e. you can actually isolate sperm from the ejaculate, then you probably don't need microtessie. You probably can use that ejaculated sperm with ICSI, for example. But microtessie is often reserved for those men who are deemed azoospermic. Success rates are very much judged by the person doing the microtessie. If you look at worldwide success rates in those who perform microtessie often, probably about 50%. In the US, Schlegel, who is the man who is kind of pioneered microtessie, he reports success rates of around 57% of sperm attained at microtessie, and most practitioners who I work with report around about the same. So in men who have no sperm in their ejaculate, about 50% of them, sperm will be found when they perform a microtessie. So hopefully that has answered your question. May, would you recommend genetic testing before implantation if fertilized with donor sperm? I think pre-implantation genetic testing is a valuable tool, particularly for older women who have a good egg count. I think that is the population of people who are best served by doing pre-implantation genetic testing. It's going to kind of deselect embryos, reducing time to pregnancy. And so I think it's really got nothing to do with the donor sperm and everything to do with the age of the woman and her ovarian reserve. Life of Brit, do you have to do ICSI if it's recommended? Can you try a normal IVF way? Egg chooses its own sperm first. Well, there are actually only a few criteria where ICSI is actually recommended. So sometimes clinicians recommend ICSI for non-evidence-based reasons. So there's a few criteria. So you can certainly ask your clinician to go ahead with IVF. What is the possible downside? I suppose failed fertilization. So failed fertilization is one of those reasons why we move on to ICSI. Sperm that is collected from the testis, so through a biopsy, a fine needle aspirate, or under microscopy, that sperm is immature and so tends not to fertilize the egg, and so ICSI is recommended there. It used to be that PGT ICSI was recommended for pre-implantation genetic testing. Now the accuracy is such that you can probably get away with doing IVF. Low egg numbers is not an indication for doing ICSI. Anti-sperm antibodies, so high anti-sperm antibodies is an indication. And previously frozen eggs is also an indication. So there are actually very few indications for ICSI, but definitely have a chat with your clinicians. Sandy Jayasi, are there any testing for implantation in the uterus before FET? Well, there are lots. There are lots of things to do, but often we don't extend investigations unless we have an issue with recurrent implantation failure. So that is where you have transferred 3 good quality embryos or more, and there has not been a pregnancy. If those embryos have been tested using PGT to determine if they're chromosomally normal or not, generally if you've transferred 2 of those, so deemed chromosomally normal, and no pregnancy, that would be an indication to go. And my dog has come in with something in his mouth. You should see him. He's just had a haircut. It is rather humorous. So yes, lots of different testing. I won't go there because it's a really long answer, but yes, there are things that you could do. Hey guys, any more questions before I wrap things up? Remember that the man is as important to consider as the woman. 30% of infertility is male related. Do not dismiss the poor semen analysis and say, hey, that's okay, we've got IVF and we've got ICSI to overcome that. Often a poor semen analysis is the canary in the coal mine, and so it's really important to investigate the guy. Make sure you ask him if he's on any supplementation, and never forget to ask if he's been prescribed any hormones. Nancy Pham, last question. Is suppression with Zoladex 6 to 12 months necessary after endolap surgery for adeno? Okay, so we don't do surgery for adeno. Adeno is the growth of the lining of the womb within the wall. There is no guideline to suggest that surgical treatment of this is going to improve fertility outcomes. Endometriosis surgery, I guess it depends on the stage of your disease. So mild, minimal mild disease, often that's enough. Doing surgery is enough to improve potential outcomes over the next 6 months. But severe disease, sort of stage 3, stage 4 disease, certainly a discussion point, particularly if there hasn't been complete resection of the disease. I certainly think there is a discussion point to be had with medical downregulation, especially if you have, you've gone to all that effort of creating embryos and you're transferring them and they're not actually sticking, even though you've done endometriosis surgery. I do think that there is a role for medical downregulation. All right, guys, I am going to wrap it up for tonight. Got to go and do some maths homework with my daughter. Yay! And rescue whatever is in my dog's mouth. Have a beautiful rest of your night. I will see you in spring next week. Yes. Have a good one. Bye.